Stiff person syndrome is one of the rarest, most misunderstood neurological conditions. In December of 2022, Celine Dion announced she had been diagnosed with a rare neurological condition that was causing her muscles to seize up uncontrollably, making it impossible to sing or even walk normally. The condition? Stiff person syndrome. Before her announcement, most people had never heard of it. But for the 1 in a million people who have it, it is a life-altering, progressive, and often devastating diagnosis. This syndrome is a progressive autoimmune disorder of the central nervous system. It is characterized by two hallmark features: progressive muscle rigidity, especially of the axial muscles of the back, abdomen, and thighs, and episodic painful muscle spasms that can be triggered by noise, touch, stress, or sudden movements. It was first described in 1956 and was originally called stiff man syndrome. It is progressive, meaning it gets worse over time, and without treatment, it can lead to permanent disability. It affects approximately 1 to 2 people per million, making it extremely rare. Women are affected twice as often as men. Most patients develop symptoms between the ages of 30 and 40, though onset can occur anywhere from 20 to 60. Only 5% of cases occur in children. Importantly, SPS clusters with other autoimmune conditions, particularly type 1 diabetes, Hashimoto's thyroiditis, vitiligo, pernicious anemia, and celiac disease. If you see a patient with multiple autoimmune conditions presenting with muscle stiffness, SPS should be on your radar. Here is the key to understanding SPS. It all comes down to GABA, the brain's primary inhibitory neurotransmitter. Normally, an enzyme called glutamic acid decarboxylase, or GAD, converts glutamate to GABA. GABA acts like the brake pedal on motor neurons. It keeps muscles from contracting when they shouldn't. In SPS, the immune system produces antibodies against GAD65, the anti-GAD65 antibodies, which blocks its conversion. Without GABA, the motor neurons fire uncontrolled. The result? Continuous involuntary muscle contraction, rigidity, and episodic explosive spasms. The clinical picture of SPS is striking. Patients develop a slow, insidious onset of axial rigidity. The back becomes board-like, the abdomen becomes rigid, and an exaggerated lumbar lordosis develops. Episodic spasms can be so severe that they fracture bones. Triggers include sudden loud noises, light touch, cold temperature, and emotional distress. Over time, many patients develop profound fear of open spaces. They are afraid to leave the house because a car horn or a sudden touch could trigger a fall. Gait becomes abnormal, and falls become a serious safety concern. There are 4 main clinical types of SPS. The classic SPS, which accounts for 70 to 80% of cases, is associated with the anti-GAD65 antibodies and has the typical axial rigidity pattern. Partial SPS variants include stiff limb syndrome, where only one limb is affected, and jerky SPS with myoclonus. PERM, which stands for the progressive encephalomyelitis with rigidity and myoclonus, is the most severe form, involving autonomic instability and brainstem involvement, and is associated with anti-glycine receptor antibodies. Finally, the paraneoplastic variant, accounting for 5 to 10% of cases, is associated with anti-amphiphysin antibodies and is linked to breast, colon, lung cancer, and lymphoma. Here is perhaps the most important clinical pearl about SPS. It is almost always misdiagnosed. The average time from symptom onset to correct diagnosis is over 7 years. Patients are commonly told they have Parkinson's disease, multiple sclerosis, fibromyalgia, anxiety, or a psychosomatic illness. This is because the symptoms, the muscle stiffness, spasms, fear, and emotional triggers can look like psychotic conditions or other neurological diseases. As an FNP, recognizing the pattern of axial rigidity plus trigger-sensitive spasms plus autoimmune history should prompt you to test for anti-GAD antibodies. Diagnosis of SPS requires a combination of clinical findings and laboratory confirmation. Clinically, progressive axial rigidity, episodic painful spasms, and sensitivity to external triggers. Laboratory, you'll see the anti-GAD 65 antibodies in the blood, the cornerstone of diagnosis. In some cases, GAD antibodies are also found in the cerebrospinal fluid. EMG is critical. It shows continuous motor unit activity at rest, which is the electrophysiological hallmark of SPS. MRI of the brain and spinal cord is typically normal, but it is done to rule out other causes of rigidity. One of the most board-tested nuances of SPS is understanding the GAD antibody titers. Anti-GAD antibodies are also elevated in type 1 diabetes, but at low titers. In SPS, the titers are dramatically higher, up to 10,000 times higher than in type 1 diabetes. This distinction is critical on the boards. If you see a patient with a high titer anti-GAD antibodies, not just mildly elevated, think SPS. Additionally, the presence of GAD antibodies in the CSF strongly supports the diagnosis of SPS over type 1 diabetes. The first-line treatment of SPS targets the GABA deficits. Diazepam, the benzodiazepine, is the cornerstone of symptomatic treatment. It enhances GABA activity at GABA A receptors, reducing muscle spasms and rigidity. Baclofen, a GABA B receptor agonist, is used as a muscle relaxant and is often combined with diazepam. Adjunct options include gabapentin and tizanidine. The goal of symptomatic treatment is to enhance the inhibitory tone that the anti-GAD antibodies have disrupted. For patients who do not respond adequately to symptomatic treatment, immunotherapy is the next step. Intravenous immunoglobulin is the most evidence-based option. A landmark NINDS-funded study showed IVIG significantly reduces stiffness, improves gait, and decreases sensitivity to noise and stress. Rituximab, which depletes B cells and reduces antibody production, is used in refractory cases. Plasmapheresis, which physically removes antibodies from the blood, can provide short-term benefit, particularly in paraneoplastic SPS. Steroids may be used short-term for acute exacerbations. The treatment landscape for SPS is rapidly evolving. In December 2025, Kyverna Therapeutics announced positive top-line data for KYV-101, a CAR T-cell therapy targeting CD19 positive B cells in SPS patients. This represents a potential paradigm shift, moving from managing symptoms to potentially inducing long-term remission by eliminating the B cells that produce the pathological antibodies. Stem cell transplantation is also under investigation. While these therapies are not yet standard of care, they represent the most exciting frontier in SPS treatment and are worth knowing for the boards. Here are your top 5 board pearls for stiff person syndrome. SPS is an autoimmune disorder. anti-GAD 65 antibodies are the hallmark. GAD titers in SPS are dramatically higher than in type 1 diabetes. High titers mean SPS. The EMG shows continuous motor activity at rest. That is the electrophysiological signature. First-line treatment is diazepam plus baclofen. Both enhance GABA. IVIG is the most evidence-based immunotherapy, and SPS is commonly misdiagnosed as anxiety, fibromyalgia, or Parkinson's. The key distinguishing feature is axial rigidity, which triggers sensitive spasms in the setting of high-titer anti-GAD antibodies. In conclusion, stiff person syndrome is rare. Know the antibodies, know the mechanism, and know the treatment. For more FNP board review content like this, visit the fnpreview.com.